So let's talk now about Propofol. So Propofol, as we talked before, the onset of action, we said that yesterday, 30 seconds, which is arm to brain circulation, meaning that it doesn't take time for the propofol to put the neurons to sleep, it just takes time to transport the propofol. Duration of action is 10 minutes, right, which makes it very favorable. And then, of course, the half-life is different. It's about 6 to 8 hours. Okay? Let's talk about some characteristics of propofol. Number one is dissolved in something called egg lecithin. Egg lecithin is a fatty acid that comes from the egg yolk. So remember it this way, it's white, but it comes from the yolk. Okay? And so it carries some implication. The first implication is that, do we ask patients about egg allergy before we give propofol? No. Right? We ask about allergies. Maybe they can say they have food allergy, including egg or something. But I'm not aware of anybody like specifically ask about egg allergy, although maybe we should, just to be safe. But the good thing is that we get away with it all the time. Why? Because most people who are allergic to eggs are allergic to what? The egg white, the albumin. They're not allergic to the egg yolk, right? So that's why we get away with it, even if they're allergic to eggs. And if you have a patient that says allergic to eggs, you can ask them that question. You say, do you boil the egg and eat the yolk? Some people boil the egg and take the white out and eat the yolk. Or they can add the yolk to the salad or whatever, right? If this is okay with them, then you can document it and use propofol. Number two, because it's a fatty acid, it has 10% fat. So the nutritionist will go crazy on you if you start or stop propofol on somebody without telling them, because they need to adjust the tube feeds and a TPN. For the TPN is easy because the TPN comes fat and others, so they can remove the fat, for example, right? But for the tube feeds it's difficult, so because it's all together. So they reduce the rate and then they start giving what? Whey protein or bena protein. They want to keep ordering it. You know why we're ordering this protein? Yeah, because we're reducing the whole amount. So that's the 10% fat. Next number is triglycerides. It has a lot of triglycerides, so it will raise the triglyceride level. And we also get away with it for the most part. Why? Because what's the harm of having high triglycerides? Pancreatitis. So I would say, there's a very, very rare case reports that show that it could be a triglyceride-induced pancreatitis with triglycerides less than 1,000. So let it be. Just keep going and measure triglyceride every 3 days until it goes above 500. When it goes above 500, don't play that game anymore. Or when the lab tells you the sample is lipemic, we can't measure anything, you stop giving propofol. All right. Next number is sepsis. So propofol initially, when it was introduced, it used to be called Deprivan, by the way. When it was introduced, it was introduced about 20 years ago or so, and the anesthesiologist actually killed few patients with it. How? The typical anesthesiology practice at that time was to actually keep draw blood. Draw all the syringes for the next case, and for the next case, and for the next case, and they put them in the drawer. And then if it's not used today, they might use it tomorrow, for example, right? That doesn't work for propofol. Well, it doesn't work for any. Nobody does that anymore. But it doesn't work for propofol specifically because it's like a culture medium, right? So what happened is that it had a lot of bacteria growing in it, and then they injected in somebody as if you're giving E. coli in somebody's blood. So the people, few cases of actually death from sepsis. Anyway, so the rule now is that if you open a vial of propofol, you can't use it in 4 hours. That's it. You have to discard it for 4 hours. And if you draw a syringe of propofol, you also can't use it for 4 hours. After 4 hours, you can't use it. And even the nurses in the ICU, when they have propofol infusion, they have to change the whole system, the tubing, between 8 to 12 hours. Like after maximum 12 hours, they have to change the system. And that's why the propofol companies they never make 500 bag of Propofol. They make 50 and 100. So the nurse is forced, and it's glass, so it's not, you can't you can't keep spiking it, right, or whatever, unspiking. So you have to change it, right? So they force you to change it. All right. Next is Propofol can give you green urine. So it's not in everybody. So in some people, Propofol will give you green urine. Okay, fine. You know, we'll take it. Just quiz the intern and move on, because there's no significance to it. You know, and don't try to link it to Propofol infusion syndrome. It has nothing to do with anything. It's like rifampin giving, and we don't know. Some patients have it and some patients don't. All right. Number 3, Propofol is anticonvulsants. It's one of the best anticonvulsants. Because as I said before, if you give a large induction dose of 2 to 3 milligram per kilogram, the patient will have isoelectric activity. So if you're having a bad seizure and the patient's intubated, or you're planning to intubate, give him that, intubate, and then you gain ground over the seizures. Then you give the Keppra and everything else, and you know, really, okay. So it is anti-convulsant, but you have to actually read the literature correctly. I left once before and got somebody here who was like, yeah, you know, I just graduated or something, and at the end of the 3-day weekend, I came back and said, "How's your," like, rhetorical question? I'm not asking for an answer. You know, how's your weekend? This is the worst weekend of my life. I said, what? He needed to say, he never came back. But the worst weekend of your life, like you never had somebody die in your family or accident or anything. This is the worst weekend of it. What happened? Anyway, so one of the things that were happening is that there was a patient on 5 medications for seizure. We have him on Propofol also because he's continuously seizing, and he continuously seizing on Propofol too. So he read something, case report, that shows that there is seizure associated with Propofol. And unfortunately, this is one of the evidence-based bullshit that we have to deal with, right? Is that this wasn't seizure. I guarantee you, Propofol doesn't cause seizure. It causes myoclonus. It's been known since the inception of right, that it can cause some. You see it more with etomidate, by the way. It causes. I've seen it a lot when I inject etomidate. You see the patient do like this, especially if you don't paralyze the patient, obviously, right? Propofol can sometimes you get a little. So people think that this is seizure and reported in the literature. Now it's stamped for the rest of, you know, the life on Earth, that Propofol can cause seizure because somebody published a case report, right? So this guy found that he stopped the Propofol, and the patient went crazy. Like the seizure was completely uncontrollable, and he spent a bad weekend here. So yeah, Propofol stops every seizure. I guarantee you that. All right. So anyway, next number. Propofol is antiemetic. So, and this is off-label, obviously. So, if you're in a oncology floor, and a patient you tried everything, if you use 1 cc of Propofol, it's used a lot in the recovery room, by the way. If you use 1 cc of Propofol, which is 10 milligram, which doesn't put anybody to sleep, nobody's gonna stop breathing or sleep from 10 milligram of Propofol. It actually takes care of the nausea. So, something that anesthesiologists use in the recovery room sometimes. Just don't tell anybody because they're gonna write you up. Next number is bronchodilator. So it is the drug of choice if you have an asthmatic that is intubated. It's bronchodilator. Next number is it decreases the ICP and decreases intraocular pressure. So if you have somebody with open eye, it decreases, you use Propofol. It decreases the ICP because it decreases the CMRO2, cerebral metabolic rate. And the CMRO2 and the cerebral blood flow are like this. They go together, right? Every time the CMRO2 goes up, the CBF goes up. And when the CBF goes up, the ICP goes up. Huh? So compared to all the other medications that are available for sedation, the other medication can cause, they don't actually have the same capability of reducing the CMR2. They actually have like a plus and minus. So basically, they leave it the same. They don't affect the CMR2. The brain, obviously, brain takes the blood before any other organ takes the blood. Like it has preferential. So basically, this is the curve for CMR2 and CBF, for example, right? If you change that to renal, it will go like this. The CBF is going to be plateaued at a certain point, even though the renal metabolic rate it keeps on going up, right? See, for all organs are like that. The brain just takes for a long time, it doesn't plateau. So, on a tangent, when you do like this, go to the gym, and moving your hand like this, for 5 minutes, and doing that exercise, very, very fast, very rhythmic. And then leave the gym, and as you're leaving, we're measuring your lactate. And if you have seizure, and you do the same thing for 1 minute, right? And then we measure your lactate. Which one will have the highest lactate? The higher lactate. The seizure, it's the same amount of minutes, same number, same movement, everything. The seizure or the carrying weights? The seizure guy. Why? Because during the seizure, it's not only that you're doing like this, your brain is also very, very active and pulling the blood up and pulling the cardiac output, and in the same time ordering the muscles to do this. So that's why the lactate in seizure shoots all over the place, right? Because of that. So let's talk a little bit about. We'll talk about Propofol infusion syndrome. Right? This is bullshit, by the way. This doesn't exist. Take it from me. There's nothing called Propofol infusion syndrome, but unfortunately, there is something called Propofol infusion syndrome. So I have to respect it. I have to change my practice to conform with the publication about Propofol infusion syndrome, because everybody wants to, play it safe, and it's fine. I like to play it safe, but I guarantee you this thing is going to be debunked. And I'm very good with predictions, by the way, so wait. 5 years from now, somebody's going to say, there's nothing called Propofol infusion syndrome. And that somebody's probably not going to be me. But, so, let's hear the story. So let me tell you something, just so you know. Propofol infusion syndrome, they said, they went to Central Main Hospital, and they found that, or the publication came from Central Main Hospital, and they found that there is, they found some people that died. And they said, okay, well, they were all on Propofol. So that's the common string. They found that these people had died. I think the first publication was like 12 patients or 13 patients, something like this. And they found that if you have more than 60 mics per kilo per minute for more than 3 days, that was the common of Propofol. That was the common factor where these people died. Okay? So I'm not gonna bore you with the details, but just think about the first case. I'll tell you the first case. First case, was, out of the 12 that they described. The first case was somebody who's 25-year-old with a car accident, so they have an increased ICP, right? So the ICP is 40, and they are on Propofol because they're in the neuro ICU, so you have to be on Propofol. And after 5 days or so on the Propofol, the patient just died. So it must be the Propofol, right? It's not the ICP of 40 that's supposed to kill you in minutes, right? It has to be the Propofol. So of course, you can see that the loose connection, and there's no mechanism, there's no mechanism suggested even that why would Propofol kill people. They say there's some metabolic acidosis. Propofol doesn't cause metabolic acidosis, so we don't know why these people die, right? It just happened for them to be on Propofol. I'll tell you something similar. When we were young, they were telling us, when Propofol was new, Propofol is contraindicated for anesthesia for kids. You can't give it to kids. Why? It was like, what? It's a different species? Like they have a different enzyme? Tell me something. Respect my like at what year you start be able, like 17 or 18 in a day, maybe, I don't know. Why kids die from Propofol? of course, somebody probably overdosed them, or few people overdosed them. They have a different volume of distribution, and they have, and they don't have a lot of reserve, not like adults, right? So the room is not, and of course, when you overdose somebody, and something bad happened, did you think the anesthesiologist is going to say, "Oh, I give him 100 milligram"? No, I give him 20. You have time to calculate now. Oh, I give him 25 milligram. What is a syringe? Nobody knows. Nobody knows. So I'm telling you, these cases were fallacies, right? But they affected the practice for some years until some anesthesiologist said, "The hell with it. I'm giving it. I'm not gonna watch this baby go through, an inhalation induction when he has an IV. I'm not gonna torture him for inhalation induction. I can just give him So they give a propofol, and nothing happened, and no new literature says that it's actually safe. Just give it. It's fine. The practice overcome. Same thing here, right? So obviously in my practice I respect this number. I don't go above 60 for more than 3 days, but I can go more than 60 for a few hours, right? So we can go up to 200 mics per kilo per minute to put very agitated patient to sleep, but for maximum 4 hours. After that you have to go down, right? So just to be out of respect for this, I have a lot of suspicions about this publication, because it's the same publication. It comes from the same hospital where one of the biggest, basically founders of the Presidex company come from. So I'm suspicious. I'm not saying anything. All right. Next thing is, let's talk about propofol for dead people. No, propofol for anoxic brain injury. So basically, what we say is that you have somebody with anoxic brain injury. You don't want to mix and match keep giving other medications left and right, and then affect the patient wakefulness, right? Because Versed, fentanyl, all of these medications affect the brain in a certain way. If I give you Versed, I know the pharmacodynamics. I know you're probably going to wake up at that time. But if I give it for somebody with injured brain, you really don't know what's the pharmacodynamics is going to become. He may go to deep sleep and then go 24 hours and suddenly snap out of it. Who knows? We can't guarantee that. So that's why we don't like to give Versed and fentanyl for patients who are with anoxic brain injury if we can help it. We try to stick to propofol. So this way we can turn the propofol off and do a neuro exam and tell the family, look them in the eye and say, I am 100% sure that your father is never going to wake up. I can't go be in a family meeting saying to the family, I'm 100% sure, but it could be from sedation. We're waiting. So, of course, you're telling me there's a chance. Of course, there'll be bad family, there'll be bad kids if they let go of their father. If there's 1% chance that he'll wake up. So anyway, the point is that you want to stick to the propofol. The problem is that propofol is not analgesic. And by the way, our policy for brain death, that we can't pronounce somebody brain dead if somebody give the patient Versed and fentanyl for the last 24 hours. So, and it's fair. I'm actually being a little bit more aggressive, because usually it used to be 48 hours. And 48 hours from toxicology stuff. If you have something in the urine, 48 hours, obviously we can go around it. If there's hemodynamic, there's a lot of things that you can do, like a brain scan and maybe a couple of other tests and stuff, but you can't do the apnea test, for example, right? And a neuro exam is not 100%. So we'll stick to the propofol, but the propofol is not analgesic. And the nurse will come to you, and she's advocating for the patient, and she's gonna cry. It'll be like tears. You'll see the tears, actually. And she'll say, you're a bad doctor, you're torturing my patient, and you're letting the patient have, you're leaving the patient in pain. How does she know that the patient is having pain on propofol, anoxic brain injury?
But they're having myoclonus, and
So the myoclonus,
she thinks that's...
Well, maybe, but that's wrong. So she's wrong, but she could be right, actually, that the patient is having pain, or there's something painful in the patient. Tachycardia and hypertension. Sometimes there's tears coming out from the patient, which is parasympathetic. But anyway, so tachycardia and hypertension, very well known. That indicates that there may be pain. We see it in anesthesia all the time. You go to the OR. Do you think the anesthesiologist run fentanyl drips in the OR? No. They give fentanyl boluses, right? So if the anesthesiologist is busy on his phone or, sleeping, and he forgot to give the fentanyl in 45 minutes or something, the patient will have tachycardia and pain. So you look, okay, give him fentanyl. I forgot, right? So if I forgot and slept during the OR, do you think the patient will wake up and say, you forgot, 12:45, you did not give me the fentanyl. I felt the pain. Of course not. He's not going to say I felt. He's asleep, right? When the surgeon is operating in the belly, for example, and then decides that he's going to just take a skin graft now. So he comes out of the belly and take a skin graft. The skin is more stimulating than the viscera. So it will actually result in sudden tachycardia. And why didn't you tell me? Give him some fentanyl, okay? And the point I want to make is that all of these are pain, but the patient is not feeling it. So this is coming to a little philosophical. It's almost like the resurrection after death. Nobody will know. Maybe I'll be wrong at the end, but nobody actually knows what these people are feeling. But I can guarantee you they don't remember anything. So just bear with me a little bit. So do you know that Versed has antegrade amnesia? Retrograde amnesia. Meaning that if I'm giving you anesthesia and I forgot to turn the gas, right? And oh my God, the patient is paralyzed and there's no inhalation anesthetic and they already started the surgery 5 minutes ago. Okay, 5 milligrams of Versed, and that will cancel out the 5 minutes before. Because nobody knows how the memory is made, by the way, but the rough understanding, the way I simplify it to myself, is that memory is made by messenger RNA. So you have a stimulation, messenger RNA starts to code for protein and go around, and messenger RNA, that's the little short-term memory, right? And then once the messenger RNA makes a protein, that's it. It becomes a long-term memory. You can't get rid of it. So that's why the last 5 minutes you can actually cancel it with, it's like almost Men in Black. That's it. So that's actually a true phenomenon. We see it all the time. So I borrowed an expression from anesthesia. Anesthesia has something called MAC, which is minimum alveolar concentration. That minimum alveolar concentration of inhalation anesthetic that put half the people to sleep. And there's something else called MAC bar. Bar is barring autonomic response, meaning that the MAC for sevoflurane, for example, is whatever 1.2 or something %, and this one is 3%. Meaning that I can put you to sleep with 1.2%, right? But in order for me to prevent you even from having the tachycardia and the hypertension response to pain, I have to put you on 3%. Okay? But that doesn't mean this is asleep. This is just additional, blocking the sympathetic and the parasympathetic, right? So I borrowed this term for Propofol, ED90 and ED90 bar. So ED90 is 50 mics per kilo per minute. We know that, everybody, right? That's what usual dose, and people, 90% of patients will be asleep on this dose. ED90 bar is the amount of Propofol that should be used to prevent even the sympathetic response, which is 200 mics per kilo per minute. And it's actually, this dose is used. Where? In neuro anesthesia. Neuro anesthesia, they don't use gas anesthesia, it's dirty. And it keeps the patient asleep for a long time and stuff like that. They want to wake the patient right up, right? So they put the patient on Propofol and remifentanil. Both of them very short acting. At the end of the case, they stop it, they can examine the patient immediately, right? So they use 200 mics per kilo per minute because they don't want to see the tachycardia and hypertension, okay? So, do you know that when we give the patient Versed in the holding area, in anesthesia, so I meet you in the holding area, you're having cholecystectomy, I give you 2 milligrams of Versed, I have a full conversation with you about your dog and your family and whatever, and then we wheel you to the OR, you're talking throughout the whole thing until you get intubated, and then we ask you, hey, do you remember anything? No, I don't remember nothing from the time you gave me the Versed and I had all of this conversation with you, I don't remember nothing, right? Even though you look awake. So the amnesia is very easy to block as opposed to unconsciousness. So is this nurse right? Going back to the nurse that was crying about the patient is having pain. She's right. The patient is having nociception. There's like a pain that's going all the way up. It goes to the brain. It actually translates into, it's supposed to translate into consciousness, sympathetic, and other things, right? So it goes to consciousness. Consciousness is blocked with propofol. Sympathetic, it gives you tachycardia and hypertension and all the other effects of pain. So this patient is having nociception but doesn't have conscious perception of pain, right? So I don't know what to say about that, except that this pain is not registered. Nobody's feeling that pain. Not the patient, not the next patient, not the nurse. The nurse maybe is feeling the pain, and I'm feeling the pain. But nobody else is feeling the pain. Maybe God is writing, there is pain in room 16 in the ICU at this hospital where nobody's feeling it. So we'll keep it, and when Hitler comes up, we'll inflict pain on him or something. Maybe. Maybe that will be the answer for that pain. If you really want to assign that pain, you can assign it to somebody. But this patient is not having pain. He will never complain of pain. When he wakes up, he's never going to say, I had pain. There was no sequela of pain. There was no long-term or short-term sequela of pain, even though he didn't give him pain medicine. And even though he was responding autonomically to the pain. So the last graph I'm going to draw for you is a graph of the effects of different effects of Versed, for example, or any drug that works on the brain. For amnesia, I need a very small amount to cause amnesia. For unconsciousness, I need a little bit bigger amount. Unconsciousness meaning that the patient now is asleep, it's like closed his eyes, like looks sleeping, right? That needs a bigger amount, right? Because you can put patients to sleep with, general anesthesia with Versed, right? 20 milligram is the dose here. For immobility, much bigger amount. And the nurses in the ICU always confuse the unconsciousness and immobility. You can't be unconscious and doing like this. That's fine. That's good for you. That on the vent you're moving a little bit. That's required. They try to mix these two, like let me. If he moves, then I have to give him more sedation because he's feeling it. He's not feeling anything, right? He's unconscious, but he's moving for reflexes and stuff. And then for autonomic responses is the highest, right? So think about it that way. When we paralyze somebody, for example, in the ICU, we take the chance actually to decrease the Versed, not to increase the Versed. Because I was using the Versed for all of these three initially, and now the patient is paralyzed, so I just use it for these two. Just I make him unconscious and amnestic. So you end up using less Versed. Obviously, you have to monitor it because the patient is paralyzed, but you end up using less Versed when you paralyze somebody than before paralyzing the person. All right, and that is it. We'll stop here.